So this was a phase 3 randomized study asking if adding nab-paclitaxel to gemcitabine in the adjuvant setting would be beneficial compared to gemcitabine alone. And the trial is a little bit complicated to interpret, and we're going to probably need to wait and see a little more mature data. The pre-specified primary endpoint was a radiology review committee response, looking at progression-free survival. And it's really the first time that anyone has tried to use a blinded radiology panel to determine the endpoint for the study. The hope was that that was going to add rigor and clarity to the endpoint. By that pre-specified endpoint, it's a negative study with no meaningful difference between the outcomes with or without the nab-paclitaxel added to gemcitabine. And of course, when you add nab-paclitaxel, you do increase toxicity and you substantially increase cost. However, a pre-planned secondary analysis was investigator-adjudicated progression-free survival. That shows a clear and substantial benefit for the addition of nab-paclitaxel. And the preliminary look at overall survival also shows a benefit for nab-paclitaxel. So I would be reluctant to say that it's routine standard practice now. I would certainly say that for patients well enough for modified FOLFIRINOX, that would still be our standard for post-surgical treatment of pancreatic cancer that's fully resected. For patients who cannot tolerate it, the options would be gemcitabine plus capecitabine. That would probably be what I would go to until these data mature, although there are some investigators that would say that these data would support allowing the use of nab-paclitaxel plus gemcitabine in a selected population that was not well enough for modified FOLFIRINOX. No question, if the patient is good performance status, well enough for modified FOLFIRINOX, that would be our preferred frontline standard.